Okay, we are now going to finish our conversation about the Clostridia genus. So as I mentioned in the last video, back in Jamie Lopez, we talked about C. perfringens, which is obviously a cause of myonecrosis and cellulitis and even a gastrointestinal infection. We also, in your last block, talked about C. difficile, which obviously is a major cause of watery diarrhea, foul-smelling watery diarrhea, and occasionally pseudomembranous colitis or megacolon, depending on how intense the involvement is. In the last video, I talked about C. botulinum, and I normally teach C. botulinum and C. tetani together because it's a good compare and contrast, right? We want to keep in mind the differences. So C. botulinum causes that descending flaccid paralysis. And now we're going to talk about C. tetani, which causes an ascending rigid paralysis. So let's talk about the neurotransmitter, or sorry, the neurotoxin that results to this different form of paralysis as a result of this infection. So first, just some main characteristics. This is a large motile gram-positive rod, just like all of the Clostridia. And also, just like all of the Clostridia, it's a spore-forming organism. We can find it in the soil, in the gastrointestinal tract of some animals, so you can actually pick it up kind of anywhere. The kind of old tale about C. tetani is people stepping on a rusty nail that's, sticking out, and that leads to a kind of injection wound, and then the wound closes up, which creates a nice anaerobic environment. And that's good because this is an anaerobic organism. If the spores are on the nail, that's fine. They'll survive, right? Because the spores will be fine in the oxygen. They're hardy. But then once they get injected into a nice environment like your foot, if you're walking around barefoot in, I don't know, a construction site, which doesn't seem like a wise thing to do, you could have the wound close up a bit, and then you would be able to grow this nice anaerobic organism in a place you wouldn't want to, like your foot. And then, like C. botulinum, it produces a neurotoxin. Okay, so let's talk about how we're actually going to develop rigid paralysis as the result of walking barefoot through a construction site. So the spores are going to enter the wound. The organism itself, like I said, is highly oxygen sensitive, but the spores aren't, so that's okay. As the bacteria enter the wound, the oxygen is going to become limiting as kind of aerobes in the area eat up all of the oxygen. As the oxygen becomes limited, anaerobic growth occurs. When this anaerobic growth occurs, you get spore germination and vegetative growth. During vegetative growth, you're going to get production of the two toxins that are associated with tetanus. These are known as tetanospasmin and tetanolysin. Tetanospasmin is basically produced when the cell is lysed, and that's actually what's responsible for the disease associated with tetanus. So it's actually associated with the organism kind of getting to this vegetative growth, and then some of these cells dying, so as you get natural turnover or as nutrients become limited. So as the cell dies, you're going to get production of tetanospasmin. Now, just like we talked about with C. botulinum and myasthenia gravis, we're once again worried about the ability of snare proteins to basically move neurotransmitters where they need to go across the synaptic cleft, okay? So when these snare proteins are pretty important, and I'm going to leave them to Dr. Hepner to explain to you, but they're going to basically direct all of our neurotransmitters where we need to go. And in this case, we're talking about two different neurotransmitters. So far, we've talked a lot about acetylcholine. At this point, we're going to talk about glycine and GABA. GABA is gamma aminobutyric acid. I say GABA because it's a lot easier. Both of these are considered inhibitory neurotransmitters. So we talked about acetylcholine, which is kind of an activating neurotransmitter. These are inhibitory. So these are what allow your muscles to relax, whereas acetylcholine is what allows your muscles to contract. So without glycine and GABA getting where they need to go across the synaptic cleft, your muscles are never going to relax. So they're just going to stay rigid. The tetanospasmin in this case is still cleaving snare. And when it cleaves snare, it basically makes it so that glycine and GABA don't go where they need to go. And that's what leads to your muscles always being contracted. And that is kind of the phenomenon that is associated with tetanus. So the tetanus toxin is actually the second most potent toxin in the world, second only to botulinum toxin, which I talked about in a separate video. And both of these lead to some form of paralysis. One of the things that I think kind of underlines how potent this toxin is when we look at the immune responses that are made. In tetanus, the disease is entirely manifested by the toxin. It's not really due to the bacteria at all. It's due to the presence of the toxin. So certainly the bacteria being there and then dying and producing the toxin is important, but all of the symptoms we see are due to the toxin. And what's interesting is the amount of toxin that you need that's actually going to lead to death of a patient is so much lower than the amount of the bacteria that you would need to cause an immune response. So what does this actually mean? Let's say I got exposed to vegetative bacteria, C. tetani, and I mounted a really effective immune response and I killed off the bacteria. I should be protected from tetanus, right? Wrong. What I'm protected from are C. tetani bacteria, not the toxin. The toxin is what's actually going to cause disease. I need to make antibodies to this toxin in order to be protected from it. And if I just got infected and made an immune response to the bacteria, I won't have had time or strength probably to make an immune response to the toxin before it was able to kill me. So this is one of those ones where vaccination and passive immunity is really helpful, because if we can block this toxin while we give the patient's body time to make antibodies to the toxin, we can actually then protect them not only in that moment from that current exposure to the toxin, but also to future ones. So let's talk a little bit about the diseases that we associate with tetanus. And remember, we're talking about rigid paralysis here. So you're going to see a couple of main things, and the idea is generalized tetanus. So the most common form is basically paralysis of the masseter muscles here, and that's what's going to lead to lockjaw, or as this patient is showing, rhesus sardonicus, which is probably the most characteristic symptom. It's this smile basically that's resulting from this sustained facial contraction. The other thing we sometimes see is known as opisthotonos, which is this persistent back spasm. The other thing that we think of is the same thing that we think of in botulinum. With botulinum, we worry about respiratory paralysis. The same is true in tetanus. It's just the opposite. Instead of the muscles being too relaxed, they're too contracted. Same thing happens though. We can't then expel the air, so we can't get new air in. So once again, we're worried about, in this case, they call it respiratory embarrassment. But patients die as a result of respiratory complications most of the time. And in this case, it's actually a 30% mortality rate. And it's basically exhaustion of the chest muscles and respiratory failure. This baby down here, this is showing you neonatal tetanus. So neonatal tetanus, we typically associate with an initial infection of the umbilical stump. So why is this? Cultures have all sorts of different practices surrounding major life events, weddings, birth, death, and there are some cultures where the cutting of this cord is kind of a big deal. In the US, many times if you give birth in the hospital, dad is allowed to cut the cord, and there's some poor medical student standing behind dad in case he passes out. In some cultures, there was apparently a practice for a period of time that it was considered kind of good luck to rub the stump in either dirt or cow dung. Why? I don't know. It's cultural. You can't really understand it unless you're a part of it. And what happened here is that unfortunately tetanus can be found in dirt and in cow dung. And in those cases, that would actually lead potentially to neonatal tetanus. Thankfully, this isn't a common practice, but when it occurs, mortality is almost 90%. Neonatal tetanus is very, very serious. So obviously creating good sterile environments around any sort of open wound and not rubbing open wounds in dirt is always good practice. Okay, so let's talk about diagnosing, treating, and controlling tetanus. Diagnosis in this case is kind of a funny one. We don't wait to diagnose tetanus. You have a patient who comes in and says that they were walking around barefoot in a construction site. Go ahead and give them a tetanus booster. There's no harm in it. But let's say you do encounter a patient who's got a rhesus sardonic grin and an incomplete vaccination history. You know, tetanus is probably a good thing to keep on the differential. So the symptoms are fairly obvious, and you should certainly suspect it if the patient's history is incomplete and their exposure risk is high. But for the most part, we really aim to go for prevention through vaccination of at-risk individuals. And prevention is actually pretty easy. So first off, we've got a great vaccine. It's the tetanus toxoid vaccine. It lasts for approximately 10 years. It's a very, very effective. Anytime we're talking about a toxoid, all that means is that it's a chemically altered form of the toxin. And that's actually kind of important to note. So we're not giving them the actual toxin itself. Normally it's been fixed with formaldehyde or something of that nature. So it's a chemically altered toxin so that we can make an antibody response to it, but it's not going to affect our neurotransmitters. The toxin can only be cleared if you have antibodies before it enters the cell. So by making the antibodies to the toxoid, you're actually having a nice present pool of antibodies to block it before it even starts to attack your muscles. Now, let's say you have a patient come in who was walking barefoot through a construction site, and the last time they were vaccinated was, 15 years ago. Is vaccinating them enough? No, you're going to want to do a little bit more. So in this case, you're going to use passive immunization here. So we actually have human IgG that will neutralize the unbound toxin before it enters the nerves. And what you're going to do is you're actually going to give both the vaccine and passive immunization, okay? And you're going to do it at 2 separate spots. So I might give the vaccine in this arm and the passive immunization over here. Why? Let's say I put the vaccination here and the anti-toxin antibodies there. All that's going to happen is that my antibodies are now going to bind the vaccination toxoid, right? Because they need to be similar for the antibodies that you make to bind it. So all you're going to do is bind up your vaccine instead of binding up the toxin that is locally produced. So you're going to want to put this passive immunization kind of near your wound. I'm going with walking barefoot through the construction site again. And then you're going to give the vaccine at kind of a slightly separate spot to kind of prime the immune response as well. And that's pretty much the whole story.